Today we'll be hearing from Dr. Ron Tamler, who is our final internal speaker for this Grand Round season. He is someone who our division is very lucky to call our resident digital health expert. He is in fact the health systems director for digital health implementation. In this role, he's been especially instrumental in helping our entire health system transition swiftly to a telehealth platform at the start and throughout the pandemic. This was, of course, no small feat, as it included training thousands of care providers. Dr. Tamler's areas of clinical interest include diabetes, men's health, telemedicine, and digital health, of course, in which he is broadly published. He also served as the medical director of the Sinai Diabetes Center and Institute from 2011 through 2018, prior to transitioning to his current role. So today we'll be hearing him speak on the intersection of two of his areas of expertise, digital health and diabetes. So without further ado, I'm going to hand the mic over.
Thank you very much, Dr. Nosova. Wait a minute, let me just, originally when we piloted this, there was only one box and now there are so many because there are more people. So let me just adjust my view here. There you go. Thank you very much for having me. It's such a great pleasure to give endocrine and diabetes grand rounds, not just to my own folks, but also to a whole crop of applicants who, some of whom may be joining us. It's very exciting. It's very exciting for several reasons. For one, I graduated this program many years ago. I had hair back then, in 2006. And so I'm a product of this fellowship program. The other reason why this is so exciting is because a lot of the stuff that I'll be presenting that's homegrown research has been facilitated by residents and fellows at Mount Sinai. As you are hearing about this topic, you can imagine the incoming data, the opportunities for working together, and the cool stuff that we are doing here at Mount Sinai. So without further ado, the topic of this talk is mobile health solutions for diabetes and weight management, which is a mouthful. It used to be there's an app for that. I gave versions of this talk at the ADA, at ACE, and over time, it turned out that the old title is just no longer true, and we'll get into that in a moment. There you go. At present, I have nothing to disclose. That is hopefully going to change. Eventually, I'll hopefully have something to disclose, which will be good for my checking account. I will use brand names of various apps and mobile health solutions. So at the end of this, you should be able to have a sense of what's out there in terms of mobile health solutions and apps and things that are useful for your patients in the world of diabetes and in the world of weight management. I want to start off with a case that's a real life case. This truly happened. So this is a 60-year-old lady, not this particular lady who's from a stock photo. She's had diabetes for a while. She's got the trifecta, right? Hypertension, hyperlipidemia, diabetes type 2. And as is often the case, the phone rings and she has to answer the phone, of course. She can't just swipe it away. So we know that she has a smartphone. She's on glimepiride and metformin and then a bunch of other stuff. And of course, she did not bring her glucose meter. But, and raise your hand if you've heard this story, my sugars are always 100. They're always fine. They're always 100. I always check my sugars. They're always 100. And the A1C is a little high, right? 9.4. It does not quite compute with a blood sugar of 100. Sometimes hypoglycemia, which she treats with juice. How do you know that you have hypoglycemia? Oh, I know. So there's no data. I'm unable to really make a recommendation for her. So she is asked to come back and she brings in a handwritten glucose log. And this is her log. And as you can see here, what are the odds that this really computes for the math whizzes here? What is the likelihood that every single measurement ends in a 0 or a 5? This defeats all laws of probability. So what's going on? Well, clearly our A1C machine must be broken, right? Or the glucose meter is broken and it only spits out numbers with a 5. Now, this can happen. There can be a discrepancy if the patient is using outdated test strips. Then, of course, that can lead to a discrepancy or some weirdness that invalidates the A1C. Or maybe there's a tool that can transmit the patient's data to us and also empower the patient on the spot, right? I mean, yes, we can prescribe a CGM and then see in the continuous glucose monitoring tracing whether this is real or not. But also we can provide a tool that empowers the patient, right? That can help the patient on the spot analyze blood glucose patterns and track things and communicate with us. That can be motivational, and that's always on her person. And maybe if we prescribe insulin, it can help her calculate an insulin dose. So could there be such a tool? And, 10 years ago, the saying was, there's an app for that. That is so pre-2010. Now there's a mobile health solution for that. And we'll get into that, what that means. And it all goes into mobile health or mHealth. And mHealth is essentially practicing health with digital portable gizmos, right? Anything that uses a mobile device and is used in the service of practicing medicine or public health is mobile health or mHealth, which is actually quite a lot. Mobile health is part of electronic health or e-health. So if you're using an electronic medical record, that's e-health already, but it's not mobile. You're kind of stuck in the, in front of the computer. So mobile health is the mobile part of electronic health. And essentially it's using any kind of mobile device to practice medicine, to do medical research, or to practice public health, or to get information from the patient. Now, back to electronic health or e-health in diabetes and weight management. As you can see, the oldest study that I'm aware of in electronic health is from 2003. Now, think about where the internet was in 2003. Many people did not have an email address or were signing on to AOL for a 56K. That was fast back then. Some people were still on 14.4 baud. At the time, it was revolutionary that in this intervention, researchers were offering basic internet for free versus internet plus a behavioral counseling program that had a one-year intervention that was intermittent. And it turns out that the e-counseling group over the internet lost more weight than just the group that got internet. So there is a study effect that you can see, the group that just got internet also lost some weight, and they had better waist circumference. So this was the first, and this was not so much aimed at diabetes, this was aimed at weight loss in diabetes. Something that we looked at Mount Sinai, based in part on what you just saw with the lady and the expose, was we looked at whether people actually bring their glucose meter to the appointment, because that's how we get usually our data on blood sugar. And so we went through 215 clinic patients and a larger number of faculty practice patients. Faculty practice patients at Mount Sinai Hospital on our East Campus are typically commercially insured, whereas clinic patients typically have Medicaid, and about 2/3 were treated with insulin. We found that only 30% had reliable blood glucose data as defined by bringing in a glucose meter that you could download, as opposed to just saying, I test it and it's this and this. Now, the clinic patients who had reliable blood glucose data were much more likely to improve their A1C than those that didn't. And you can speculate on whether they're more motivated, whether they're more into the management of their diabetes. You can speculate whether the doctors and the providers have better tools to then respond to the data. What's interesting was, in contrast to our sample patient here, in the example, bringing in the log was actually helpful and did not change the overall analysis. So I got into this whole thing back in 2006 after a parent of a 20-year-old patient with type 1 told me, you know, nobody brings in their meter, but everybody carries their cell phone. This was in 2006. I was like, you know what? That's very true. This is not the parent, by the way. This is just some random guy from a stock photo. So you know, everybody carries a smartphone, and smartphones. The term was coined in the last millennium, actually. So it's not just a cell phone, it's a cell phone that can do other stuff, mostly that has an internet browser. I think at this point, that's what we define a smartphone as. To the point where now flip phones have become a rarity, although they are coming back as smartphones if you've got a Galaxy Z3. Now, you don't need a smartphone necessarily to have a successful intervention. You can do it lower tech, just with texting. This is a study out of India that was tied to the workplace. And this is a common theme. Large employers have figured out that diabetes is a major driver of cost and of absence from work. And so employers try to prevent people, employers with foresight, try to prevent people from getting diabetes and want people to manage their diabetes better so that they miss less work and that they incur less cost to their insurance base. So this was over 500 men, young and middle-aged men with pre-diabetes. And they got either just generic lifestyle training, you know, eat this, not that, or they got the occasional text message. You know, conversion from pre-diabetes to diabetes in that population was pretty high, 27%, but only 18% in the intervention group, which is weird because there was no other difference. There was no difference in the self-reported diet. There was no difference in BMI. So I'm not sure how exactly that was accomplished, but it does count as a success. So this is low tech, right? This is just texting. This is not even app-based. And, you know, the reason why smartphones are such an interesting target is because almost by law, everybody in the US now has at least one smartphone. Some of us have several. And in part, it's codified by law, right? Some people will say, I have an Obama phone. And if, depending on your phone plan, you will see carved out like $1 that goes to, $1 of your phone taxes goes to paying towards a fund that enables everybody to have a phone. So everybody has a cell phone, but not everybody has a smartphone. Most people have a smartphone. Well, who doesn't have a smartphone? Mostly the elderly. This is fairly recent data. So this is not data from like 2010. So if you're looking at the older population, up to half will not have a smartphone. That they might have a flip phone. So that's important to know as we're thinking about interventions. The people who did not receive education greater than high school are less likely to have a smartphone. People who have less money are less likely to have a smartphone, and people who are not in the city or the suburbs. But by the same token, those are also the people that don't have broadband or a computer. So if they do have a smartphone, they kind of leapfrogged the whole laptop computer stage, and they went straight to being connected to the internet just by smartphone. Also important, especially after the recent Facebook outage. I don't really do Facebook, so I was not that impacted. But for some people, life as we knew it ended when Facebook was out a few days ago. Almost 3/4 of the U.S. population uses some form of social media, and that's important to know because that tells us how we can drive influence campaigns that are beneficial to our patients. Are patients using apps? Again, we turned to our own population. This one, so the previous Mount Sinai study that looked at whether people brought in glucose meters was run by one of our former fellows, Julian Boyd-Boshinko, who's now a successful attending physician. This one, our patients using apps, we just went into our waiting room, and Anna Ross, who's now at the Brigham, asked them, okay, do you have apps? Do you have a smartphone? What's going on? And so we surveyed 125 diabetes patients, and overwhelmingly they had cell phones, but not everybody had a smartphone. Now, this is a few years ago. I think that the share of smartphone owners will be higher by now. And even then, remember, they had Blackberries then still. That was still a thing. But even then, you could see that it was Android or iPhone. And most people were using apps, but almost nobody was using a diabetes app. And then once they heard, I could do something with diabetes, a lot of people were interested in downloading something to help their diabetes. And we found a large educational divide in smartphone ownership. And also along with the educational divide, likely a socioeconomic divide. So I told you that I had to change the title of my talk. That's the way it normally works, right? You give a talk and kind of evolves over time, and you add to it and you update it so that you don't have stuff from 2003, unless it's a foundational study. So originally the title of this talk was "There's an App for That," but that is changing. So before 2010, I would say, doctors prescribe medication, and then around 2014, forward-thinking providers may have prescribed an app. And, I have here, doctor prescribes an app. To be honest, most of the time it was the diabetes educators who were more knowledgeable about this and were closer to what's working for the patient and what isn't working for the patient, because this involves their daily lifestyles. So should probably change that to provider prescribes an app. And now, what's happening is that the app is really just part of a greater ecosystem between hardware and other apps that are not directly related to diabetes. It's possible that it's not you recommending the app. It's possible that they get contacted by their health insurance or by their health system taking care of them to say, there's this great app that you should download, or this great mobile website that you should visit. And it's rolled into other stuff. Well, thinking about what kinds of apps there are, obviously there's reference apps, right? There's textbooks, cookbooks, all kinds of stuff. And then there are the old-fashioned apps, right? Like Glucose Buddy. I just a few weeks ago got an email from somebody looking to study apps in diabetes, and they said, I heard about Glucose Buddy, and that's the most downloaded app, which is true, except that Glucose Buddy is kind of dead because those self-contained tools have gone away. But they're still downloadable. It's just that they're far less likely to be used. So these standalone apps are decreasing in their use because everything is connected now. But sure, you can download an app to track your sugars. You can download an app to scan a food label. But again, increasingly, these are rolled into other solutions, right? You can scan a food label with Google Lens, and it's going to work just fine. So increasingly, you have mobile health or mHealth solutions. For instance, your glucose meter comes with an app these days, right? You can buy a Bluetooth connected glucose meter for $20, and it comes with an app, and it can analyze your stuff. Or your CGM comes with an app. And the app is actually really good at this point. So it's rolled into that. Or the latest thing is that there's some kind of analysis, AI, that can either be facing the patient, helping the patient make decisions on the spot, or it can be provider facing and guide you in analyzing all these reams of data that are now coming in. And then finally, a lot of apps are trying to do what is called engage the patient, meaning tying them in, as opposed to you see a patient, then you don't hear from them for a year, and during that year, their A1C is 15, and then they come back when they need their refill. This is meant to keep a patient connected and engaged, and to educate a patient, and maybe educate a patient on the spot as they're living their life, because everybody always carries their smartphone. So once you have that, you get an ecosystem of apps, of hardware solutions, of players that are interested in the welfare of the patient. And now, I don't know why the Plus didn't make it to the third-party payers. That is not a snide comment that I dislike third-party payers and insurance. It's just a formatting issue. But you can see how many people are interested in interacting with the patient via the app, right? Or via mobile health. So you've got pharmacies who obviously are interested in selling people stuff and making sure that people get their refills, because every time they get their refills, they sell stuff. You can, obviously, we as clinicians are interested in adherence and communicating with our patients. Researchers can get tons of data, can recruit with apps. Pharma, very interested, not just in selling stuff, but also in avoiding patients dropping medications. So if you educate patients, hey, you may experience nausea if you use Ozempic, and here's how you deal with it. Then they are less likely to stop this medication, which of course then helps the pharmaceutical company. So you've got a whole set of stakeholders enveloping patients, trying to use mobile health because it reaches the patient where the patient is. And increasingly, you've got these stakeholders working together. So one example, you've got this conglomerate of, Bigfoot Insulet, which is a pump company, Omada, which is a diabetes prevention company. We'll talk about that. Novo, which makes insulin, and other pharma. Sanofi, which makes insulin. Tandem is a pump company. They're all working together on mobile health platforms. Then you've got, for instance, Roche, which bought My Sugar, which is one of the most popular apps. Roche makes blood glucose meters, and then Boots, which is, Walgreens. And then you've got other collaborations. So increasingly, you've got these stakeholders getting together and building out platforms to encompass a patient. Now, one of the questions that I get a lot is, okay, these apps are clearly telling patients to do stuff or collecting data. How is this regulated? It turns out that before, I would say 2013, 15, something like that, it was kind of the Wild West. And you had all kinds of apps and they were not regulated. And now the FDA is regulating apps to a certain degree. An app needs FDA clearance if it is part of a device. So for instance, you may have heard that the Freestyle Libre continuous glucose monitoring device, Libre 2, in contrast to the old Libre, you couldn't use a phone to scan the sensor, which with the old version, you could. And the reason why you couldn't do that was because the FDA was holding up the clearance for the companion app for many months. And so anything that turns your phone into a device has to go through the FDA. But anything that is used in monitoring and analysis, in diagnosing a condition or in treating a condition, really the FDA wants to know and wants to send this through the process. Kind of a little bit more of a gray zone is anything that provides specific recommendations. And so what you may have observed is that a lot of these insulin dosage calculators that you used to find on the App Store have quietly gone away because they really don't want to be in that pickle of having to justify to the FDA, look, we're not really a device, right? We're essentially a calculator. So that's something that the FDA has been having their eyes on. Apps do not need FDA clearance if they're just for education, or, like the Google Play Store does not need to be certified for FDA clearance. And then there's a big gray zone where the FDA may decide that they want to have to approve the app or not. So, medication trackers, personally, I think that is not really something the FDA should get into, but, they explicitly reserve that as something that they may want to review. Communication platforms to the patient, because you may make a recommendation to the patient as to how to respond to certain situations. And then checklists for diagnosis, because by checklist, you could then make a diagnosis. And then also from a checklist, for a diagnosis, it's a very small step towards artificial intelligence, then making the diagnosis. Our own Zach Bloomgarden wrote a very nice article 10 years ago saying, you know what, mobile health, mHealth, can really help the 5 M's of adherence, right? Messaging, motivation, monitoring, money, and helping patients save money and optimizing affordability, and mobility. So it was very foresightful and still holds true today. One concept that comes up every once in a while is gamification. And gamification means you're applying the dynamics of a game to something that's definitely not a game. Right? Taking care of your blood sugar is not a game. We're not playing games with sugar. However, maybe there are ways of making it fun. And, there are all kinds of examples from the educational world where gamification has been very successful. So maybe this can carry over to diabetes education or to behavior modification. And in a way, you could say that having, a certain challenge, right? Take this challenge, where you pledge, I'm going to keep my sugar under 200 for the next 7 days or something like that. And you put that out on social media. That too could be considered gamification. So far, there's not a whole lot of published evidence that it works well. Really not a lot of studies, but increasingly people and app developers are turning towards the concept because Just intuitively, it makes sense. But the underlying data for this is not that compelling. So, an entire talk about diabetes apps, but maybe they're not all that useful. For type 1 diabetes, there is no data that shows decisively that standalone apps for type 1 diabetes make a dent. For type 2 diabetes, if you take the various meta-analyses, so they usually find about a 0.5 point reduction in A1C. The quality of the various studies is highly variable. And in general, if you look at these 510K FDA applications, it's usually like 100 patients. It's tiny number. It's not comparable to, say, the like the COVID vaccine, where you have 30,000 patients in each arm. It's not comparable in numbers, the research that we have in apps compared to any actual pharmaceutical. So the question is, how do I know that an app is good? And like with anything on the internet, how do I know that anything is good, right? There's a lot of manipulation. There's manipulation of the App Store. There's mechanical Turks, which is essentially fake reviewers writing fake reviews. The same thing that plagues Amazon is also plaguing the various app stores. So one thing is to go, the most downloaded app must be the best app. Turns out that is totally not true, because the most downloaded app is the free app. So it's great, it's free, but then what happens is people use it once and then leave it on their phone and never use it again. So just the number of downloads is really not a good criterion. And this is something that we studied here at Mount Sinai with Andrew Demidovich, who at the time was a resident and then went on to do fellowship and is now technology attending. The other thing that we found was really only a tiny number of apps are solidly built on both evidence-based medicine and what is called usability heuristics, which is a very fancy term for being built in a way that people want to use it and that they're easy to use. You should really beware of star ratings, again, because there's so much manipulation. So sure, you can infer certain things from the number of downloads. If you have something that has been downloaded 2 million times and they have a 5-star rating, it's probably not terrible. But if you have something that's been downloaded 50 times, chances are that the author's cousins have provided the great reviews. The other thing is, there are not that many non-English apps. Increasingly, the commercial apps are now getting translated. The quality of the translation is very variable. I mentioned that increasingly devices now come with their apps, and those are typically the best apps, right? They were developed by professionals. They were developed based on usability heuristics because they actually spent the money to do this properly. And they did focus groups on patients. And so usually those are the best apps, these companion apps. And so, CGM tracing, blood glucose tracking, pump operations, and then sharing data. All of these are mobile health solutions that are not from a standalone app. They are from an app that comes with the device that you got. And they make the device so much more useful, right? I mean, if you have a CGM, that's nice, but if you have a CGM that constantly uploads and can let your provider look at your blood sugar tracings anytime, that is much more useful. Probably one of the best reviewed diabetes apps is My Sugar. God forbid we have any vowels in app titles. This is an Austrian app that was bought for a few tens of millions of dollars a few years back by Roche. It turns out that was a great investment. And, there's a free version, which is actually pretty useful. And there's a pro version, and they have like COVID pricing, have had COVID pricing for the last year and a half. So I think that the $30 might be waived or might be reduced right now. And so that's a pretty good app for just keeping track of stuff. And having a calculator that's approved, that's proper, a bolus calculator that you can put in there for insulin. It will sync with the Accu-Check blood glucose meters because Roche bought it. But you can also use it as a standalone app, and then you type in your stuff. So if a patient, especially on insulin, asks you, I want an app, this could be good. Increasingly, you have a situation where apps are part of a solution or an ecosystem that is pushed by an insurance company or by a health system, where you really cannot be the one prescribing the app and tell the patient, oh, just download this from the App Store, but rather it's the patient's health insurance that will tell them, hey, we're paying an arm and a leg for your diabetes care, and we bought a solution that's going to help you. WellDoc is one such solution. They were actually the very first diabetes app to get FDA clearance. And they've expanded now to be a mobile health solution for high blood pressure, CHF, behavioral health. It kind of makes sense because few people have only diabetes. Most of our patients have multiple things wrong and need to track multiple things and need to communicate about multiple things. So this is a way to track stuff, and then it gets communicated to the cloud and then back to the providers. There is a prospective randomized controlled trial from 10 years ago, back when they got FDA clearance for diabetes, showing 2 points in A1C reduction, which is massive. This is at about 200 patients total in primary care. And then more recently in a study with NYU, they showed an A1C reduction of 1%. But I have to tell you, the starting A1C was 10%. Typically, when you do anything in a patient with 10%, just by touching them, you get some reduction in A1C. So I'm not sure that it's that powerful. Sorry, so this is not NYU. This is from Health and Hospitals Corporation. So, it brings everybody together, the insurance, the carriers, the physicians, and the patient. You cannot prescribe this. This is something that an insurance company will buy or a health system will buy. And so you've got lifestyle recommendations on the go, not just the tracking. You've got a whole bunch of connected devices, all glucose meters, blood pressure monitors, all kinds of stuff that go into the app, not just the sugar, and you don't have to type everything in. So this is very comprehensive, but you as a clinician will not be able to prescribe it. Then there's Virta Health. Virta is banking on keto diet, ketosis diet. Keto is now the new South Beach, right? Everybody wants to do keto and they don't really know what it is. So this is truly a ketotic diet that they're pushing and monitoring via the app. So this is the hardcore actual thing. And so they are finding in an open label study that 2 years in, a majority of patients are still doing well and have not yet died, and that they have lost weight and using fewer medications as they are losing weight. So the real keto diet needs to be monitored by a provider team. That's not something that people should engage in just by themselves. I have to tell you, I once sent a patient to Virta, so I have an N with one, and they were not happy. They found that as they were trying to learn about the program, the call center agent was just trying to sell them. And so they were so turned off by that they said, I don't want to deal. But in theory, if you do pay for the service and you enroll, they will then take on the coaching and the monitoring and the supervision via the app. Then there are other startups, just like Verta, but they're fresher, they're newer, using blood glucose data and CGM data to generate insights based on artificial intelligence, right? Whenever you use artificial intelligence, you need to learn. And essentially, these apps and these startups get better the more data they acquire. And so it becomes this kind of snowballing effect because they'll have a data set to learn from. You also see how crappy, I use this at a grand rounds, how crappy the evidence is that they are supporting for whether they work or not. No control group, yes, our patients are using great, and these are the self-reported patients, and those are the patients that are just sticking with the program. We don't have data of the patients that use this for a few days and say, you know what, this is not for me. So it becomes a self-fulfilling prophecy. January AI, similar. January AI is all about blood glucose spikes from high glycemic index foods and high glucose load, glycemic low foods. So glycemic index is, defined by the food. Glycemic load is the amount of the food times the glycemic index. So, if you have just a nibble of white bread, it's not really going to spike your blood sugar that much. But if you have the loaf of white bread, it's going to, it's a high glycemic load. You too, for $500, can get their recommendations for 90 days. I would wait for a sale. Again, there's not that much proof out there that it works. There's nothing like published in peer-reviewed literature, to my knowledge, but they're getting a lot of press. So this is not an app, but it's still a mobile health solution. This is Livongo, which you may have heard of. It was taken over for $18 billion by another, by I think Teladoc, or American one of the two. Essentially, it's a glorified glucose meter that's connected to the cloud. And then on the other side of the cloud, you've got dietitians, nutritionists that will provide advice based on the numbers. So there's a protocol. If somebody has a sugar of 35, they're going to call immediately and say, "Are you still alive?" So that is not an app, but it's still a mobile health solution. Now, a lot of our patients need help with weight management. I have to tell you, I don't prescribe apps. I just tell people use the camera function in your phone. Just the very basic camera. Every phone has a camera, and every grandma knows how to use that camera because grandma's taking photos of the grandkids. So anybody can use this, and it's very successful, and it tells you not just what you're eating, but also the meal size. And so what I tell people is make an appointment with the dietitian 3 days before, start taking photos of everything that goes in your mouth, everything you drink, everything you eat. Now, if you do want to use an app, MyFitnessPal is probably one of the most successful, most downloaded. You can track your foods, you can track your exercise. It syncs with a Fitbit. Here's a study with MyFitnessPal as part of a larger behavioral intervention. As opposed to My Life, which is Vida Insana. This is more geared towards the Latino population in California. And what you see is while the intervention was going the first year, it was successful, though not nearly as successful as the original DPP. And then it just regresses once you stop. What's interesting is they didn't tell people you can't do anything else. So 19 patients, as opposed to a small, tiny number of patients in the control group, were also enrolled in other interventions. So you see the quality of these studies is not necessarily that great. Lose It is the main competitor to MyFitnessPal. It has a nicer interface. So if you have kind of a younger patient that wants the better interface, that's another option. You know, you take photos of the food, you scan barcodes, which you can also do with MyFitnessPal. Calorie King was the original Bible back in the 1990s. People had little booklets that they were carrying with them everywhere that had all the calories of a given food and the carbs of a given food. In contrast to subscription-based apps, this is just a one-time purchase. The Holy Grail is to take a photo of the food, and then the app will tell you, oh, this is how many carbs, this is how many calories, right? I mean, that's really where things need to go. Turns out that's very hard to do. There's a solution called GoCarb out of Spain and Germany that was tried out. I don't think it's gone anywhere. This is an app that you can actually download and give a try. It's called Snack with a Q. God forbid it could actually be spelled CK. This is a Swiss app, and I actually spoke with their CEO who has a girlfriend who has type 1. And that's what inspired him to build this solution and create an entire company. And they are alive with health insurance companies in Switzerland and hospital systems in Switzerland, and they are gearing up to take on the US market. So what Snack will enable you to do is it will, you take a photo of the plate, and it will then, with a little bit of work, with a little bit of an investment, it will then tell you how many carbs approximately there could be in there. And they tested it out against dietitians, and they were non-inferior. So it's not bad. I myself tried it. The photo on the right was me taking a photo of a Milano cookie, because that's what I do at 11 o'clock at night when I make my slides. I take photos of Milano cookies, and then I eat Milano cookies. And it identified the cookie, even though they don't have Milano cookies in Switzerland, even though it's close to Milan, which is northern Italy. So I was very impressed with that, and it had the right amount of carbs. Again, this is more diabetes focused, less overall calorie focused, and they integrate with with Dexcom. So the idea is to see what people's glucose spikes are, and then eventually make recommendations. Weight Watchers is probably the best reviewed weight loss program within the medical literature, and they have a mobile app that goes with their program. And you know, if people ask me for a formal weight loss program, of course I would recommend the Mount Sinai weight loss program first. But if that's not in the cards for them, then I do recommend Weight Watchers as an option. Noom is very popular increasingly. It's fresher than Weight Watchers. It's got a lot of behavioral kind of tricks. I will get to questions at the end of the talk. So Noom has some behavioral tricks, and based on the diabetes prevention program, not cheap. So they are trying to market to health systems and to insurance companies. If you want to get Noom on your own, you have to pay an arm and a leg. Omada, similar business model. They really don't want patients to download the app themselves. They want to be a part of an ecosystem with the health system or with an insurance company. They started out as a diabetes prevention app. And so what they do is they have these sessions, these diabetes prevention education sessions and motivational sessions that you have. There are 16 sessions. They have that as part of essentially a larger Zoom gathering, if you will, through their app. But they've expanded to include physiatry, not psychiatry, physiatry, which is important to all the back pain patients, right? Hypertension, behavioral health. So they've gone bigger than diabetes now. So there is a group in Australia that runs, just like JD Powers publishes, what are the best cars. There's now this group in Australia that has de facto become the arbiter of what is the best weight loss app. They started in 2015 and they've been publishing a new list ever since. So they like Noom the best, but you can see here all the many of the usual suspects that I just presented are reviewed and on that list. So in summary, and then I'll get to your questions, mobile health, because it resides with the patients at all times, can have an immediate impact, right? You're right there on the spot, you get feedback on the spot. And you can use it for all kinds of stuff, but importantly, you can use it to engage the patient, bring patients in, to communicate to the patient. Surprisingly, a lot of the standard apps are not evidence-based at all, or they have a poor user interface. That is gradually changing as apps are becoming part of an ecosystem, and it's a big money game. The FDA may regulate an app depending on what it does for you. And again, we're moving away from this thing of, let me give you an app, to I'm going to give you something that becomes part of a mobile health solution, part of a greater ecosystem. And with that, I'm open to questions. Let's look at the chat. Thank you, very interesting. 3 questions, 3. Do you think apps help to engage people who are less engaged, motivated about their diabetes care, while versus helping people who are already pretty engaged to begin with? I think it's a bit of both. I think that, especially if you have some degree of gamification, if you catch people at the right time, the app can make a difference. I have to also tell you that, so for instance, for medication adherence, I use stock apps. So I tell people, put in your calendar app an alarm. And it's not a specific diabetes app. It's just, a calendar reminder, but it's mobile health, right? So I think that there is some truth that people are into their condition and are more neurotic, are more enthusiastic. But it is possible that apps can be helpful in making things easier. Do people engage with the app for a few weeks and then stop, or do they engage longer? So that is the that depends on the app, and it depends on the condition that they're using the app for, and that is precise. So, for instance, the CEO of Snack very proudly told me, and 50% of our patients still engage with our app 4 months after download, which is spectacular, right? I mean, that means that they are very successful. Then do apps help reach out? But it's very individual by the app. And that's exactly as I said. Most apps are downloaded once, people try it out and say, and then they're never deleted. Do apps help reach out to people in rural locations where you mentioned people might be less likely to have smartphones and where access to diabetologists might be a problem? So that is absolutely the case. But apps are just part of this whole mobile health thing. So whether we call it an app or whether we call it we're giving our patient a tablet so that you can have a video visit, and with that, we're giving them mobile broadband, and it's all through a mobile website. It's all flowing together. It's no longer the app alone. It's the app and the entity that stands behind it. Michael Villa, I suppose each app has its own website for physicians to log in with a different password that needs to change every 30 days. And wait, password has to be, at least one small letter, one big letter, one number, and one special. Are there initiatives to have any of these platforms directly connect with EMR? The answer is yes. So Mount Sinai is obviously very interested. So first of all, there's Apple Health Kit, which aims to collect and then own all that data, right? So that's one. Google has something similar. And then there are the various portals, right? Epic and the like. And then there are middleware companies that are making a killing. So I'll give you an example. There's a company called Redox, which integrates, has a deal both with Abbott for the CGM Freestyle Libre and for Dexcom to bring in to Epic CGM data. And so you can make a deal with Redox and get data from your patient directly into Epic. So the answer is yes, eventually. But what's going to happen is going to be similar to what we have with LabCorp and Epic and Quest, where eventually we're going to try to figure out ways to bring that in. But as you can see, this has been going on for a while. We still don't have Quest Labs in Epic, only LabCorp. And then yes, some apps can be connected for free. Good review. Thanks for mentioning the Tornado, but it's disappointing that although a decade ago we thought that apps were going to be an answer to everything, relatively little has happened. Evidence of outcome benefit is mainly lacking. Comments. You are correct. So I think that the bar for apps has been so low, has been set so incredibly low, and the evidence base is so shoddy, but it's such a big business that everybody just assumes that apps are the thing to do. And now with telemedicine being a big component of care, I think people are just going for it. I've had good success with Noom, but for older patients, cost is prohibitive. Any word if they will cut back on costs in 2022? I have not heard anything about that. Thoughts on balancing the clinical need for the data. We have 2 minutes. So clinical need for the data and the increasing focus on data security, privacy, and the multiple administrative layers that have been created for review but slow down clinical progress. I have thoughts, but they are not for this forum. I'm sorry. I think that data privacy is going to be a big topic once you have the hacking of the first prominent type 1 patient, right? Once Nick Jonas has his glucose data published, I think it's going to be big in the news and there's going to be a big blow up. The likelihood of AI replacing the MD and DM. So I like the word game here. The regulatory moat is considerable. And so what you're going to have is you'll have AI as a decision-making tool, the same way that AI currently exists for EKGs and has existed for the last 15 years, right? A version of AI, a primitive version of AI has been telling you this EKG is probably normal sinus rhythm, but it takes an MD to then sign off on it. We'll have something similar where, and we already have kind of versions of this with the meal bolus monitor with Medtronic, where it says, you know, you have this going on, you have that going on, maybe you should pull back a little. So I think that you'll have analysis tools that will be carefully vetted by lawyers, and then you'll have the provider sign off on it, and you'll have many primary care doctors getting into CGM and just signing off on the stuff or not.
So it looks like we're about at the hour. Any other final questions or comments? Sounds like no. Okay. Thank you so much for a very engaging and great talk, Dr. Tamler.